This is forward. That's back.
Okay.
And this is the pointer. This is a much stronger pointer. Okay?
Thanks. Good morning. I also want to thank the audiovisual people for allowing me to update my slides, and I want to thank Dr. Perlow and Dr. Mazur for inviting me. I did cut out a large part of the lecture that's in the handout because when I prepared the handout, I didn't realize Dr. Perlow is going to talk about shock at the end of the course, so I removed those because he can cover that much better than I can. So let's start with the definition. This is an introductory slide. I am going to speak twice, as you heard. This talk is just about ST segment elevation myocardial infarction. Later, I'll talk about patients that have non-ST segment elevation MI. You realize that they can present with ST segment elevation and then rule out or rule in, but if they rule in for an MI, they may rule in for a non-QMI or a Q-wave MI. So nothing's really changed there from the time you went to medical school. You still have to check the enzymes and look at the EKG. So a lot of people got together and formed a committee and said, we need to define what an MI is. You wouldn't think that's necessary, but they did. And they came up with a large publication. I'm showing you one slide from that publication. And the key here is that they're using biomarkers now that are preferably troponin. We don't really rely on the CK and the CKMB as much anymore. And they say you need at least one value above the 99th percentile of the upper reference limit, together with evidence of ischemia with at least one of the following. So symptoms of ischemia, ECG changes, pathologic Q waves, or imaging evidence of loss of viable myocardium, such as or a new regional wall motion abnormality. So most likely, when you diagnose an MI, it's going to be based on an elevated troponin and chest pain with or without EKG changes. So the pathophysiology hasn't changed since you went to medical school. Just to remind you that MI is in about a half of the patients with heart disease, the first event. So in this Framingham report, among 5,000 patients, the initial event was an MI or sudden death in 55% of the 159 subjects who had a new event. In patients with an acute MI who had paired angiograms, meaning they had an angiogram before the MI and then came back to the hospital with an MI, the baseline angiogram before the MI showed less than 50% stenosis of the infarct artery in about two-thirds of patients. And in part, that observation led to our concept of the ruptured plaque, which I will get to. The angiographic studies that have been done in patients with acute MI tell us something about flow. We grade flow from TIMI 0 through 3. Anything that's less than 3 is abnormal. And flow was found to be abnormal in over 90% of 500 patients with ST segment elevation MI who underwent angiography within about 4 hours after symptom onset. But you could see only 60% had no flow, meaning complete occlusion. And there are a good number of patients that have partial flow, TIMI 1 or TIMI 2 flow. This is a nice slide that I put together from several publications. And the concept now is that most patients with acute MI have either ruptured plaque or an eroded plaque. There is some gender difference in the pathologic studies. I'm not sure how important that is, but in men it was found that the ratio is 80% to 20% for ruptured plaque versus an eroded plaque, whereas in women it's more about 60-40%. The ruptured plaque is thought to be the fibrous cap ruptures, and then the lipid contents of the plaque come in contact with the blood elements causing coagulation. The eroded plaque, there's no frank rupture, there's just erosions and then the formation of a thrombus. So this is an example of a ruptured plaque post-mortem. You can see this is the lumen, this is the thin overlying fibrous cap. This is the lipid and calcium in the plaque, which has initiated the thrombosis. This is actually in a living patient. This is from Steve Nissen's work at Cleveland Clinic. And you can see here an intravascular ultrasound. This circle is the ultrasound catheter in the lumen of the coronary artery. The purple arrow here shows that there's a rent in the fibrous cap, and here this is the lipid pool underlying the cap. So this is not a pathologic artifact. This really occurs in living people. This is another IVA study from Steve's work, and this contrasts a stable plaque versus a vulnerable plaque. Here you can see a stable plaque with a thick fibrous cap. This would be less likely to rupture and cause an acute coronary syndrome than this plaque, which has a very thin fibrous cap overlying a large lipid pool. And one of the goals of chronic medical therapy with things like statins is to try to convert a plaque like this to a plaque like this. So to try to lower the lipid content and increase the fibrous content of the overlying cap. So if you came to a board question and it wanted to test your knowledge of what a vulnerable plaque consists of, these are some of the features that you would want to know. That it has a large lipid-rich core, that it has a thin fibrous cap, that the cap can be degraded by macrophage-derived products, and that there's apoptosis of smooth muscle cells resulting in impaired healing. I don't think that they would ask you that, but that's what we were told to know for our boards in cardiology. Now, I put this slide in for Dr. Perillo. He suggested this once before. This is Dawn, possibly over Long Beach Island, where he likes to spend his summer weekends in New Jersey. This is traffic in California, but I learned yesterday that the traffic here in Chicago is second to none. Fortunately, there are no earthquakes where I live or in Chicago, but you can see here this is a photo of one in Los Angeles. This is someone shoveling snow. We had quite a lot of that in New Jersey this year, and I'm sure you did wherever you live if you're in the east. Someone having an upper respiratory infection, and this is the logo for the recently completed World Cup. So what do these all have in common? These are all triggers for plaque rupture and myocardial infarction. So this was shoveling snow was reported in the New England Journal in 1996 as a trigger for MI. Also in the New England Journal in the same year, another report of an increased risk of an MI after the large earthquake in Los Angeles. Traffic was reported in 2004 as being sitting in traffic and reported as a trigger for MI. And I find that that's a stressful experience on my way home. Watching a stressful soccer match, I don't watch soccer, so I don't find it stressful, and I don't understand the sport, but apparently there have been a number of reports that watching a sporting event where you have some emotional attachment can lead to an MI. Respiratory infections certainly may ramp up the inflammatory system and in some way precipitate plaque rupture. And simply getting up in the morning is a risk. The peak risk is within 3 hours of awakening, so stay in bed. But there is a circadian variation in the risk of an MI, and it's been found in a number of studies that the highest risk is within 3 hours of awakening. Now, what about diagnosis? So here's my first question for the board review, and I took what I think is a reasonably easy EKG to see throughout the room. A 50-year-old woman admitted to the ICU from the emergency department with acute onset of shortness of breath. She has hypertension, type 2 diabetes, hyperlipidemia, and a history of lupus. Her medications include hydrochlorothiazide, metformin, gemfibrozole, and a COX-2 inhibitor. Her initial blood pressure was 160 over 100. Her initial ECG was normal, but then the following ECG was obtained during chest pain. So the question is, you would recommend A, chest CT to rule out a pulmonary embolus, B, an echo to rule out pericardial fusion, thinking, well, she's got lupus, she could have pericarditis. C, sublingual nifedipine for treatment of coronary artery spasm because you see these ST segment elevations here. D, an intravenous fibrinolytic drug, could be TPA, RPA, or TNK because you think there's an acute MI. Or E, you want to transfer the patient to a hospital that's 2 hours away for cardiac catheterization. Okay, so 70% got the question right. That's very good. I'm very pleased to see that. So this, I would not think of PE here, although PE can masquerade as an MI. And again, I would think of MI, not pericarditis here, even though you could, because of their elevation in both the inferior and precordial leads, think of pericarditis in the patient having lupus. The problem with doing a cath here is the transfer time, and we would like to have the artery open within 90 minutes. And so lytic therapy becomes the best choice in this particular patient. So this is actually the angiogram from this particular patient. I received this courtesy of Eric Topol, who was one of my colleagues at the University of Michigan a long time ago. This was the occluded left anterior descending coronary artery at the time of the ST segment elevation, and this is the reperfused artery after intravenous TPA. And you can see here the artery's open now, but there's a very tight stenosis. This is the EKG before TPA, and here's the electrocardiogram 40 minutes after TPA. And you can see the ST segment elevation has resolved completely. That's the ideal response to lytic therapy, and you would hope to see that all the time, but frequently you do not. I'll come back to that point. I do want to make a point about the fact that some patients present without chest pain. And in this large study of almost 500,000 patients with confirmed MI who enrolled in a large registry, 1/3 did not have chest pain at the time of presentation to the hospital. Why is that important? Well, because among patients with ST segment elevation MI who are ideal candidates for reperfusion therapy, meaning lytics or cath, the patients without chest pain were significantly less likely to receive reperfusion therapy, beta blockers, and aspirin. And as you would expect, because of that, the hospital mortality was significantly greater among those patients without chest pain than among the patients with chest pain, 18.7% versus 6.3%. So we really need to be vigilant when we evaluate patients who have atypical presentations. It might be shortness of breath, it might be syncope. So not all STEMIs present with chest pain. Now, looking at the electrocardiogram as a prognostic and diagnostic tool, what I want to show you here from the GC study, an Italian fibrinolytic trial, is the relationship between the number of leads with ST segment elevation and the in-hospital mortality. In the green, you see the placebo group. In the red, you see the streptokinase group. And, of course, the more the leads that show elevation, the higher the in-hospital mortality. But you can see that there is benefit, and that for each group, other than the group with 2 to 3 leads, there's a significant reduction in mortality in hospital comparing streptokinase to placebo. Now, there is a differential diagnosis to ST segment elevation that was reviewed very nicely in a paper in the New England Journal of Medicine about 7 years ago. And in the interest of time, I will go quickly through this. This is in your handout. This is precordial leads and a limb lead. And the MI is here. So here's an MI with Q waves in the precordial leads. Here's an MI with a right bundle branch block, which can make the diagnosis a little more difficult than the electrocardiogram. Now, what does the differential diagnosis include? Left ventricular hypertrophy, left bundle branch block, pericarditis, of course, hyperkalemia, and Brugada syndrome. So not all ST segment elevation can be diagnosed as a myocardial infarction. What about Q waves? Well, Q waves are present on the baseline ECG in the first 6 hours after symptom onset in about 1/2 of patients with an ST segment elevation MI, even in the patients who have never had a previous MI. The baseline Q waves, however, are associated with an increased relative risk in mortality. And the presence of the Q waves do not affect the reduction of infarct size by thrombolytic therapy. So it would be incorrect to look at the electrocardiogram and say, oh, the patient already has Q waves, so the horse is out of the barn, and I won't treat the patient. That would be an incorrect conclusion. So even though there are Q waves, you would still treat the patient. The Q waves do not develop in all patients after lytic therapy, and in fact, in about 20% of patients, they didn't develop. And the presence of a non-QMI, meaning an MI without Q waves, is an independent predictor of a lower mortality in this thrombolytic trial, Augusta 1. And finally, this interesting MRI study showed that 29% of transmural MIs did not have Q waves on the electrocardiogram, and 28% of the so-called subendocardial MIs did exhibit Q waves on the electrocardiogram. So it's incorrect to equate a Q wave with a transmural MI, and that's why we don't use that terminology anymore. And the probability of the Q wave is really related to the size of the MI and the number of transmural segments. So Q waves mean the MI is bigger. It doesn't necessarily mean that the MI is transmural. And as I said, we don't refer to transmural and non-transmural MI anymore. Cardiologists tend to live by guidelines. The American College of Cardiology and American Heart Association have committees that continuously review the clinical evidence and update the guidelines. The 2004 guidelines are still in effect, although they've been updated twice, as I'll show you. So here's the 2007 update that appeared, and I'm going to just remind you that we classify recommendations for treatment as 1, 2, or 3. Green is go, so in class 1 recommendation, the benefit greatly exceeds the risk and the procedure treatment should be performed or administered. Class 2 are somewhat less positive in the sense that we know the benefit exceeds the risk, but we're not sure that every patient needs to have this treatment. So 2A means the treatment is reasonable to perform, and 2B should be considered, and 3 means, red means stop, obviously, and class 3 means you should not institute that treatment. Levels of evidence, you're probably familiar with A, B, and C. A is the best evidence, C is the weakest. A means there are more than one randomized trial, C means there's only consensus opinion, and the B is the intermediate level of evidence. So here's a question that you might be able to answer if you've read the guidelines, but you might have some trouble with if you haven't. So after the IV TPA that the patient I showed you received, she was pain-free and hemodynamically stable. So which of the following medication orders would be appropriate? Continue her outpatient medications, discontinue the celecoxib and start aspirin, clopidogrel, and ibuprofen, discontinue the celecoxib and start aspirin and clopidogrel, discontinue the celecoxib and start aspirin, clopidogrel, and unfractionated heparin, or finally discontinue the celecoxib and start aspirin, clopidogrel, intravenous unfractionated heparin, and intravenous eptifibatide. I know this is a tough question, but it makes a number of points that I want to emphasize. Okay, so a number of you got the answer right. That's very good. Why is this the right answer? Well, first of all, the guidelines, as I'll show you, recommend that all nonsteroidal anti-inflammatory drugs be discontinued in the setting of an acute coronary syndrome, either ST segment elevation or non-ST segment elevation. And so that would basically say you stop the celecoxib and you do not prescribe ibuprofen. Secondly, aspirin should be started in all patients. In addition, clopidogrel and an anticoagulant, one option is intravenous unfractionated heparin. We do not usually give a 2B3A inhibitor, a glycoprotein 2B3A inhibitor, after someone has had lytic therapy because of the increased risk of bleeding. So there are some recommendations about proper analgesia in the current guidelines. Morphine is still considered acceptable treatment, and it's the analgesic of choice for patients with continued pain. You can see here the two guidelines related to the NSAIDs are here. Patients routinely taking NSAIDs except for aspirin, both non-selective as well as COX-2 agents, should have those agents discontinued at the time of presentation due to the increased risk of mortality, reinfarction, hypertension, heart failure, and myocardial rupture. And similarly, they say it's a class 3 indication, don't start them. So if they're on them, stop them and don't start them. Okay, so here's another electrocardiogram. 55-year-old man admitted to the ICU for treatment of pulmonary edema. His outpatient medications are unknown at the time. His blood pressure is elevated. His ECG is below. There are no old ECGs for comparison. So which of the following options is your best choice? A, furosemide, nitroglycerin, aspirin, clopidogrel, heparin. B, furosemide, nitroglycerin, aspirin, clopidogrel, heparin, and a fibrinolytic drug. C, furosemide, metoprolol, aspirin, clopidogrel, heparin, and a fibrinolytic drug. D, furosemide, nitroglycerin, aspirin, clopidogrel, heparin, emergency cath. And finally, furosemide, IV metoprolol, aspirin, clopidogrel, heparin, and emergency cardiac catheterization. All right. Well, this is a tough question. I didn't bring easy questions. The thing that the electrocardiogram shows is a left bundle branch block, and so the question is, in this patient, what would we'd want to give? Well, the right answer is we'd want to give a diuretic, obviously, because the patient is in heart failure, and nitroglycerin is useful to lower the blood pressure and treat the heart failure. You want to give antiplatelet therapy. You would like to give an anticoagulant. And the reason a cardiac catheterization, I think, is preferable here is because the patient's hypertensive, so there's a relative contraindication to giving a lytic therapy. And the diagnosis, of course, is uncertain because you don't have an old EKG and you don't know if the left bundle branch block is old or new. A left bundle branch block may be the sign of an acute MI, but it could be chronic. And so this is a case where you would not want to give a lytic agent. Now let's talk about beta blockers. What's wrong with giving a beta blocker here? Well, the patient's in heart failure. So oral beta blockers are indicated in the first 24 hours for patients who do not have signs of heart failure, evidence of low output, or an increased risk of shock. And this is relatively new. These are the new guidelines. So older patients, patients who are hypotensive, tachycardic, or bradycardic, we would withhold beta blockers in the first 24 hours. And then, of course, if they have evidence of conduction system disease or reactive airway disease, we would withhold beta blockers. Not going to say too much about lytic therapy. The class 1 indications still are ST segment elevation patients with symptom onset within 12 hours of the symptom onset and who have elevation of a millimeter or more in at least 2 contiguous precordial leads or 2 adjacent limb leads. So that hasn't changed. And that patients with symptom onset within 12 hours and a new or presumably new left bundle branch block also have a class 1 indication for lytic therapy. There are, of course, contraindications to lytic therapy. They're in your handout. Just quickly: intracranial hemorrhage, intravascular, cerebrovascular lesions, an ischemic stroke within 3 months, except an acute ischemic stroke within 3 hours. That's an indication for giving TPA. The dose is different, however. Suspected aortic dissection is a contraindication, active bleeding, significant closed head or facial trauma within 3 months. Then the relative contraindications are important. Severe, poorly controlled hypertension, as in this patient. Blood pressure that the guidelines use is systolic of 180 and diastolic of 110. And our patient had a systolic of 190. History of prior ischemic stroke, dementia, or known intracranial pathology. CPR itself is not a contraindication, but prolonged or traumatic CPR is. Avoid giving lytic therapy to someone that has a non-compressible vascular puncture, and that means a subclavian, for example. If someone has had a subclavian attempt, I wouldn't give lytic therapy. pregnancy and warfarin are also relative contraindications. This is one study among dozens and dozens, and I think it's a study worth knowing about because it really led to a change in the guidelines. This was published last year. It was done in Canada. They took high-risk patients with ST7 elevation in MI who presented within 12 hours of the onset of symptoms, and they all got a lytic drug, TNK, aspirin and heparin or enoxaparin, and clopidogrel. And then they were randomized to either standard treatment or an invasive strategy. The invasive strategy was transferred to a hospital that has a cath lab and undergo cath and, if indicated, angioplasty within 6 hours. The standard treatment was assess the chest pain to determine if the patient is reperfused or not, which is difficult to do. The criteria that were used were ST7 resolution less than 50% or persistent chest pain or hemodynamic instability. Those were considered failed reperfusion. So if the ST segment resolution was more than 50% from baseline, they were considered successful if their chest pain resolved and they're hemodynamically stable. Now, in this study, you can see here there was a marked difference in the primary endpoint of death, reinfarction, recurrent ischemia, new or worsening heart failure, shock within the first month. And you can see here that the routine catheterization was better than standard treatment. And so based on that, the guidelines were revised last November, and guidelines are very fuzzy now. And as a cardiologist trying to teach my fellows and house staff and trying to teach you how to manage a patient, the guidelines are fuzzy. And so I've included a number of slides in the handout. I may not have time to go over them. I'm not sure how many minutes I have left. A few? 5 minutes left. Okay. So they say that patients who present to a non-PCI capable facility should be triaged to lytic therapy or transferred to another hospital for percutaneous coronary intervention. And they say, how do you make that decision? Well, there are a number of things. What is the mortality risk of the patient? So higher risk patients are thought to be better managed with in the cath lab than by giving lytic therapy. Another factor is what is the risk of lytic therapy, and then I just showed you some of the relative contraindications. The duration of symptoms when first seen. They don't really talk about the impact of duration of symptoms, but it was in the older guidelines said that if someone presented within 3 hours of symptom onset, lytic therapy works better than if they present later. And so from our point of view, as an interventionalist, we feel that, well, if someone is beyond 3 hours, it's probably better to go to the cath lab than to give them lytic therapy. And then, of course, you always have to consider how long is it going to take to get them to a cath lab if your hospital doesn't have one or if it's not available. So if the patient's high risk, the patient should receive appropriate antithrombotic therapy. That means aspirin, a thienopyridine, and an anticoagulant, and be moved immediately to a PCI-capable facility for a cath. If they're not high risk, the patient may be moved to a facility after receiving antithrombotic therapy. That means after lytic therapy. So the patients that are best suited for transfer for PCI, in the opinion of the committee who wrote the guidelines, are patients with high-risk features. So that would be patients who are hypotensive, tachycardic, heart failure, high bleeding risk from lytic therapy, and patients who present late, meaning more than 4 hours after the onset of symptoms. Patients best suited for lytic therapy, according to the guidelines, are those presenting early after symptom onset with a low bleeding risk. After lytic therapy, if not high risk, you could transfer the patient to a facility, but you may also keep them unless you suspect that they've failed to reperfuse. I'm going to skip that slide and just say Dr. Perillo is going to talk about cardiogenic shock for an hour later this week, so I've kept one slide on cardiogenic shock. And you can see here that it's a Class 1 indication for PCI. Primary PCI should be performed in patients less than 75 with an ST7 elevation MI or a left bundle branch block who develop shock within 36 hours of MI and are suitable for revascularization. Now, there's a cutoff here of 75, and so in the shock trials, he'll talk about if the patient's over 75, did not do as well. So it's a 2A classification for patients over 75. Finally, adjunctive pharmacologic therapy was revised in November, and there's some new recommendations regarding antiplatelet therapy. This is the latest recommendation for glycoprotein 2B3A receptor inhibitors, which I'll talk about more in my second talk. And there are class 2A indication for either axiximab, which is a monoclonal antibody, or tirofiban and eptifibatide, which are the small molecule inhibitors of the receptor. And this is, generally speaking, performed in the cath lab by the interventionalist, not something that would be instituted beforehand. In fact, the guideline now is the usefulness of a glycoprotein 2B3 receptor antagonist as part of a preparatory strategy for patients with STEMI prior to arrival in the lab is uncertain. And so you really don't need to worry about, well, do I have to start one of these drugs before I ship the patient off to wherever, to another hospital or to the cath lab. The guidelines for thienopyridine were revised. So clopidogrel should be given. The loading dose is uncertain. 300 to 600 milligrams is the range. So you can give 300 or 600. The other option is prasugrel in a loading dose of 60 milligrams. The reason for the uncertainty about the loading dose of clopidogrel is shown here. This is a study yet to be published, but a very large study. This is the risk of stent thrombosis in patients with an acute ST segment elevation MI who came to the cath lab and got either a double loading dose of clopidogrel or a standard dose of clopidogrel. And you can see here there over the first 30 days, there was almost a 50% reduction in the risk of stent thrombosis, which I'll talk about more later, the problems with clopidogrel and its effectiveness. So prasugrel is the new drug on the block that you probably have not used. We have not adopted it widely yet, but is now available. It's indicated to reduce the risk of thrombotic cardiovascular events, including stent thrombosis, in patients with acute coronary syndrome who are to be managed with PCI. Patients with either unstable angina or NSTEMI or patients with STEMI. So really this is a drug for interventional patients. The package insert says, do not use this drug in patients with active bleeding or a history of a TIA or a stroke. This is really important because they have an increased risk of cerebral hemorrhage. In patients who are over 75, it's generally not recommended because of the increased risk of intracranial bleeding. Do not use it in patients that are likely to undergo bypass surgery. And it has to be discontinued at least a week prior to surgery, otherwise there'll be more bleeding. The loading dose is 60 milligrams. The maintenance dose is 10 milligrams. And there's a recommendation to consider lowering the maintenance dose to 5 in patients who are thin, meaning less than 60 kilograms. And they should also take aspirin. This is not a substitute for aspirin. It's a substitute or an alternative to clopidogrel. Anticoagulants. Just mention that about a third of patients who meet criteria for reperfusion do not receive any, according to large studies. In patients who did not receive reperfusion therapy, there was a study that looked at fondaparinux, a factor Xa inhibitor, and it was found to significantly reduce the endpoint of death or recurrent MI without an increase of severe bleeding or strokes when it was compared with unfractionated heparin or with placebo. So this drug seems to be a better option than heparin, unfractionated heparin, in patients who don't undergo reperfusion therapy. And you can see here the guidelines gave it a 2A recommendation. Moving ahead, in patients who undergo reperfusion with lytics, they should receive anticoagulant therapy for a minimum of 48 hours, preferably for the whole hospitalization up to 8 days. And it says the regimens other than unfractionated heparin are recommended if anticoagulant therapy is given for more than 48 hours because of the risk of heparin-induced thrombocytopenia with prolonged unfractionated heparin. So in that case, enoxaparin or fondaparinux would be considered preferable after 48 hours. You say, well, should I use unfractionated heparin or a low molecular weight heparin? There are data to address that. This study addresses that. This is the endpoint of death or non-fatal MI in a study that compared unfractionated heparin versus enoxaparin, and you can see it was significantly better or lower risk with enoxaparin in this trial at the 30-day mark. And so there were 15 fewer non-fatal MIs, 7 fewer urgent revascularations, and 6 fewer deaths with a cost of 4 more non-fatal bleeds for every 1,000 patients who were treated with enoxaparin instead of unfractionated heparin. The other anticoagulant that you may have heard of and should know about is bivalirudin. There was a large trial that compared bivalirudin with unfractionated heparin called the Horizons trial. And in this trial, the major adverse cardiac events were the same for both groups. The pink group is heparin, the green group is bivalirudin. Bleeding was significantly lower with bivalirudin, which is why we tend to use a lot of it in the cath lab. And therefore, the overall net adverse clinical events were fewer with bivalirudin. This is now reflected in the updated guidelines. So for patients proceeding to primary PCI, bivalirudin is useful as a support, and it's a class 1 indication. Do I have time to do this slide? I think it's my last slide. So this is a slide about, in the New England Journal of Medicine, about excess dosing of heparin in lytic-treated patients. Among a group of 758 patients with STEMI who received lytic drugs and unfractionated heparin, 49% received an excess dose of heparin, defined as a bolus of more than 60 units per kilo or an infusion of more than 12 units per kilo. You wouldn't think that would happen, but it was found to be the case. 137 received a major excess of heparin, defined as a bolus more than 70 units per kilo, or an infusion more than 15 units per kilogram per hour. Low body weight and female gender were associated with the excess dosing. The patients who received the major excess dosing had higher rates of major bleeding, 19%, and transfusion. And so that's something to be aware of. Do not overdose with heparin. And I'm going to go to my final slide, which is discharge medication. So antiplatelet therapy, of course. Everybody should get aspirin. The dose can range from 162 to 325 milligrams per day. It depends on whether they got a stent or not and what kind of stent. They need to get clopidogrel or prasugrel. They should get a beta blocker unless it's contraindicated. It should be continued indefinitely in all patients who have had MI, acute coronary syndrome, or LV dysfunction with or without heart failure symptoms. An ACE inhibitor is indicated, or if they're allergic or intolerant, an angiotensin receptor blocker, especially if the ejection fraction is less than 40%. There's a history of hypertension, diabetes, or chronic kidney disease. Those are all indications for an ACE inhibitor. And finally, statins should be prescribed to all patients. They should be titrated to at least an LDL less than 100, but ideally to less than 70 milligrams per deciliter. I probably ran over.